Hello students, in today's video we are going to discuss pharmacology of non-steroidal anti-inflammatory drugs, in short NSAIDs, a complete comprehensive overview. So let's begin. So first of all, what are NSAIDs? Now NSAIDs are one of the most widely used drugs. A very well-known example is of aspirin. Now as the name suggests, non-steroidal means these drugs are not steroidal drugs. They are in no way similar to steroids, like for example prednisolone. No steroid ring is present in their chemical structure. These drugs are anti-inflammatory. These drugs reduce inflammation, that is, they reduce swelling and edema. So these drugs are termed as non-steroidal anti-inflammatory drugs. Now, important thing to remember here is this, that NSAIDs not only reduce inflammation, but they also reduce pain and fever. So, these drugs, that is non-steroidal anti-inflammatory drugs, produce anti-inflammatory, that is reduce inflammation, analgesic, that is reduce pain, and antipyretic action, that is they reduce the fever also. Now, aspirin is the oldest anti-inflammatory drug, a very popular, well-known drug. Now, aspirin is an anti-inflammatory, analgesic and antipyretic drug. Now, in addition to that, it also produces anti-platelet action. It inhibits platelet aggregation. So, the platelets do not stick to each other, and this prevents the formation of thrombus. This is a figure of a blood vessel. Now, thrombus, as we know, can block the blood vessel, and blockage of the blood vessel will either reduce or completely block the supply of blood to the tissues. So, this thrombus can reduce the supply of blood to the wall of heart, or for example to the neurons, causing fatal diseases like myocardial infarction or stroke. So, aspirin being an anti-platelet drug, it reduces the formation of thrombus, and thereby it reduces the incidences of myocardial infarction and stroke. So, this is about NSAIDs and their main therapeutic uses. Now, let's understand basic mechanism of action of NSAIDs. Now, NSAIDs reduce inflammation, pain and fever. Now, what causes this inflammation, pain and fever? Now, inflammation, pain and fever are caused by the synthesis of prostaglandins. So, NSAIDs block the synthesis of prostaglandins by blocking the enzyme cyclooxygenase, in short COX. So, the main mechanism or the basic mechanism of action of NSAIDs is to block the enzyme COX, thereby reducing the synthesis of prostaglandins, and this causes or this produces anti-inflammatory, analgesic and antipyretic action. Now, NSAIDs block synthesis of prostaglandins. This is very clear to us. Now, let's understand how prostaglandins are produced, and apart from causing inflammation, pain and fever, do prostaglandins have any physiological or protective functions in the body? Now, this is a beautiful diagram, and this diagram explains synthesis of prostaglandins. Now, practically every cell in the body can produce prostaglandins. Now, each cell has a cell membrane, and this cell membrane is made up of phospholipids. Now, activation of enzyme phospholipase A2 by chemical or mechanical stimuli hydrolyze phospholipids to release arachidonic acid. Now, this arachidonic acid follows two pathways. One is the lipoxygenase pathway, another is the cyclooxygenase pathway. Now, cyclooxygenase pathway, during the cyclooxygenase pathway, this enzyme cyclooxygenase, it produces prostaglandins from arachidonic acid. Whereas, lipoxygenase pathway, in this pathway, leukotrienes are produced from the arachidonic acid. Now, these leukotrienes, they are the inflammatory mediators. They produce inflammation and they increase the inflammatory response. Now, cysteine leukotrienes like leukotriene C4 and leukotriene D4, they cause bronchoconstriction, they cause narrowing of the bronchial tract, and they also increase production of the mucus. So, this can cause asthma. Now, during blockage of this pathway by NSAIDs, most of the arachidonic acid or majority of the arachidonic acid is converted to leukotrienes. So, during the use of non-steroidal anti-inflammatory drugs, synthesis of leukotrienes increase, and that can cause asthma or it can exacerbate the asthma. Now, let's focus on the COX pathway. Enzyme cyclooxygenase produces prostaglandin G2 and prostaglandin H2 from arachidonic acid. Now, these prostaglandins are highly unstable, and these prostaglandins are further converted to prostaglandin E2, prostaglandin F2 alpha, prostaglandin D2, prostacyclin and thromboxane. Now, very important to understand that this cyclooxygenase enzyme is of two types, COX-1 and COX-2. Now, COX-1 is a constitutive enzyme. As the name suggests, COX-1 is a constituent of cell. It's always present in the cell. COX-1 mainly produces physiological prostaglandins. It mainly produces protective prostaglandins, which are very essential for the body. However, during the initial stages of inflammation, it also produces prostaglandins that cause inflammation. But the main role of cyclooxygenase 1 is to produce the protective prostaglandins. Now, all these are physiological prostaglandins. These are protective prostaglandins which are produced in the small amounts throughout the life of an individual. Now, COX-2 is an inducible enzyme. So, its synthesis is induced by the inflammation. It is produced during inflammation. And on stimulation of COX-2, COX-2 mainly produces prostaglandins that are responsible for producing pain, inflammation and fever. However, COX-2 is also protective in organs like brain and the kidneys. So, in summary, COX-1 mainly produces protective prostaglandins, and COX-2 mainly produces prostaglandins responsible for pain, inflammation and fever. Now, let's discuss the physiological actions or protective actions of these prostaglandins. Now, first is the prostaglandin E2. Now, this prostaglandin E2 is produced by the stimulation of cyclooxygenase 1. Now, prostaglandin E2 stimulates the secretion of gastric mucus. Now, look at this figure of the stomach. Mucus is shown here in the yellow color. Now, mucus produces a thick covering on the wall of stomach and duodenum. Now, mucus protects gastroduodenal wall from corrosive effect of acid, pepsin and gastrin. So, this prostaglandin E2, by producing the mucus, it protects the wall of stomach as well as the wall of duodenum. Now, blockage of COX-1 reduces the synthesis of prostaglandin E2, the levels of prostaglandin E2 fall, and that can produce the risk of peptic ulcer. Another function of prostaglandin E2 is the renal vasodilation. So, prostaglandin E2 dilate the blood vessels. So, it dilates the blood vessel of kidneys. Now, this causes increased blood flow to the kidneys. Now, increase in the blood flow causes increase in the glomerular filtration rate, another protective function of prostaglandin E2. Next is the prostaglandin F2 alpha. Now, it is produced due to this stimulation of again cyclooxygenase 1 enzyme. Now, prostaglandin F2 alpha causes bronchoconstriction. The bronchial tubes they become narrow. It also causes uterine contraction. Now, uterine contraction stimulate progression of labor, and they are found to be useful also in the delivery of child. On the other hand, prostaglandin mediated uterine contraction reduces the risk of postpartum hemorrhage. Now, postpartum hemorrhage is the bleeding that is caused after the delivery of child. So, this prostaglandin F2 alpha, it causes uterine contraction, which are found to be useful in the delivery of child and also reduce the risk of postpartum hemorrhage. Now, inhibition of again COX-1 reduces prostaglandin F2 alpha, delay the labor, and also increase the risk of postpartum hemorrhage. Now, stimulation of COX-1 also produces prostaglandin D2. Prostaglandin D2 causes vasodilation and that improves the blood supply. Now, another important prostaglandin is the prostacyclin. It is a physiological prostaglandin which is produced by the stimulation of cyclooxygenase 2. Now, prostacyclin is produced by the endothelium of blood vessels. Now, this prostacyclin, it causes vasodilation, the blood vessel dilates, and it also inhibits platelet aggregation. Now, it prevents sticking of the platelets with each other. Now, that reduces the formation of thrombus, thereby reducing the risk of myocardial infarction and stroke. Now, if this COX-2 is inhibited, that will reduce the synthesis of prostacyclin. Now, reduction in the synthesis of prostacyclin will cause platelet aggregation, and that will cause the formation of thrombus, and that will further increase the risk of myocardial infarction and stroke. Another prostaglandin is the thromboxane A2. It is produced by the stimulation of COX-1, and thromboxane A2 is produced by the platelets. Now, thromboxane has the actions opposite to the actions of prostacyclin. Thromboxane causes vasoconstriction and it induces platelet aggregation. That means the platelets stick to each other, they produce the platelet plug. Now, this platelet plug is very beneficial for the body. Now, if a blood vessel gets ruptured or if a blood vessel gets injured, which normally happens during the normal wear and tear of the tissues in the body, this platelet plug, it seals the injured site of the blood vessel and this prevents the bleeding. So, if COX-1 is inhibited, that will reduce the synthesis of thromboxane A2 and that will increase the risk of bleeding. Thus, prostacyclin as well as thromboxane, they both have antagonistic actions, but both are essential for the normal healthy circulation, and these are produced in a balanced amount in the body. Now, non-steroidal anti-inflammatory drugs are of three types. First type of NSAIDs are non-selective. For example, aspirin and indomethacin. Now, these drugs block COX-1 as well as COX-2. So, these drugs are highly efficacious. They are highly efficacious anti-inflammatory, analgesic and antipyretic activity they show. But they also show a number of side effects. Like for example, increased risk of gastric ulcer, increased chances of nephropathy due to blockage of COX-1. Further, blockage of COX-1 causes a delay in labor, increased risk of postpartum hemorrhage, high chances of bleeding. Now, second type of NSAIDs are preferential COX-2 inhibitors like diclofenac and aceclofenac. So, these drugs inhibit COX-1 as well as COX-2, but more inhibition of COX-2. So, again efficacious drug but with lesser side effect. But this COX-2 blockage, it reduces synthesis of prostacyclin, and reduction in the synthesis of prostacyclin causes more chances of the formation of thrombus and increased risk of myocardial infarction and stroke. Third type of NSAIDs are the selective COX-2 inhibitors. For example, celecoxib. Now, celecoxib, drugs like celecoxib, they selectively block COX-2. So, these drugs are highly stomach friendly as they do not inhibit COX-1. And these drugs, they do not cause bleeding. And these drugs are also efficacious and they are useful when the drug is to be used over a long period of time. For example, patients of rheumatoid arthritis, patients of osteoarthritis. So, main important feature of COX-2 is this, that they are stomach friendly and they can be used for a long time. Now, however, as COX-2 is inhibited, there is reduced synthesis of prostacyclin, increased chances of the formation of thrombus, and therefore high risk of myocardial infarction and stroke. Now let's once again review mechanism of action of NSAIDs. Now by now we know that NSAIDs block cyclooxygenase enzyme, thereby they inhibit the synthesis of prostaglandins, and this causes their anti-inflammatory, analgesic and antipyretic action. Now let's first talk about aspirin. Aspirin acetylates COX. It forms covalent bonds with the COX, and thus this blockage of COX causes irreversible inhibition of COX. So the COX becomes non-functional. Now because of this mechanism of aspirin, in addition to anti-inflammatory, analgesic and antipyretic action, aspirin also shows antiplatelet action and reduces the risk of myocardial infarction and stroke. Now all the other NSAIDs are reversible competitive inhibitors of enzyme cyclooxygenase. Now let's classify the NSAIDs. Now the first type of NSAIDs are the non-selective, block COX-1 as well as COX-2, highly efficacious but with more side effects, and therefore these are not preferred to be given for long periods. Now these include salicylates, for example aspirin, propionic acid derivatives like ibuprofen, naproxen, phenamates like mefenamic acid, enolic acid derivatives like piroxicam, tinoxicam, acetic acid derivatives like ketorolac and indomethacin. Then preferential COX-2 inhibitors. Now these inhibit both COX-1 as COX-2, but these are preferential COX-2 inhibitor. They mainly inhibit COX-2. For example, diclofenac, aciclofenac, meloxicam, then etodolac. Now these are again efficacious but with lesser side effect. And due to the blockage of COX-2, there is reduced synthesis of prostacyclin, therefore increased chances of the formation of thrombus and therefore increased risk of myocardial infarction and stroke. Then third type of NSAIDs are the selective COX-2 inhibitors. These drugs selectively block cyclooxygenase 2 and therefore these drugs are stomach friendly. They do not induce the risk of peptic ulcer and they also do not induce the risk of bleeding. For example, celecoxib, etoricoxib, then parecoxib, and these drugs are preferred when NSAIDs are to be given for long periods. For example, in patients with rheumatoid arthritis and osteoarthritis. Now another classes of analgesic and antipyretic. Now this class includes paracetamol. Now paracetamol, as we know, is the drug of choice for reducing the fever. However, paracetamol does not show anti-inflammatory activity. Now main pharmacological actions of NSAIDs. Now all NSAIDs produce anti-inflammatory, analgesic and antipyretic actions. But these drugs produce variable magnitude of anti-inflammatory, analgesic and antipyretic actions. Let's understand how. Now aspirin, diclofenac, naproxen, indomethacin, piroxicam, these are highly efficacious anti-inflammatory agents, while ketorolac, mefenamic acid are preferably used for their good analgesic activity. For antipyretic action, the drug of choice is acetaminophen or paracetamol, and it is only aspirin that shows antiplatelet action, reducing the risk of myocardial infarction and stroke. Now, the main uses of NSAIDs, as we have already discussed, NSAIDs are anti-inflammatory, they reduce inflammation, they are analgesic as they reduce pain, they show antipyretic action as they reduce the fever, and aspirin shows antiplatelet action, and it is prescribed in post-MI and post-stroke patients to prevent the reoccurrence of myocardial infarction and stroke. Another use of NSAIDs is in dysmenorrhea. Dysmenorrhea is the painful menstruation, and it occurs due to the release of prostaglandins, which cause uterine contraction, producing pain. So, NSAIDs, by reducing the synthesis of prostaglandins, reduce uterine contraction, and therefore they reduce the pain that is caused during dysmenorrhea. Then another use is in acute rheumatic fever. Acute rheumatic fever is a fever with pain in the joints. Again, NSAIDs are useful. Now, NSAIDs are very useful in reducing inflammation and pain in the rheumatoid arthritis, and they are used for reducing pain in osteoarthritis. So, see, these are some of the main uses of NSAIDs. Now, let's summarize the adverse effects of non-steroidal anti-inflammatory drugs that are caused due to the inhibition of COX-1 and COX-2. Now, inhibition of COX-1 reduces secretion of prostaglandin E2, that reduces secretion of gastric mucus. Now, fall in the secretion of gastric mucus causes gastric irritation, which further results in nausea, anorexia, peptic ulcer, and gastric bleeding. So, these are the gastrointestinal side effects of the NSAIDs due to the inhibition of COX-1. Now, blockage of COX-1 also causes reduced secretion of thromboxane A2, that reduces platelet aggregation and increase the risk of bleeding. Now, the non-selective COX inhibitors, the non-selective non-steroidal anti-inflammatory drugs are associated with the increased risk of peptic ulcer and increased risk of bleeding, like aspirin. Now, blockage of COX-2 causes reduced secretion of prostacyclin, which increases platelet aggregation, which further causes formation of thrombus and increased risk of myocardial infarction and stroke. Now, selective COX-2 inhibitors are associated with increased risk of myocardial infarction and stroke. Then, renal effects. Now, renal side effects are not significant in the normal individuals, but in patients with congestive heart failure, renal disease, these side effects are highly significant. And non-steroidal anti-inflammatory drugs should not be prescribed along with diuretics, ACE inhibitors, and angiotensin II receptor blockers. Now, blockage of COX-1 reduces renal vasodilation. This reduces blood supply to the kidneys, reduce the glomerular filtration rate, and that can result in nephropathy and renal failure. On the other hand, blockage of COX-2 can cause sodium and water retention by the kidneys, that causes increase in the fluid retention, and that further can cause rise in the blood pressure. Now, NSAIDs are also associated with a hepatic adverse effect. There is increase in the levels of transaminases, and which are characteristic of liver damage. Now, NSAID like nimesulide is not used in many countries due to liver toxicity. Then diclofenac sodium, paracetamol, they can also produce liver toxicity if used for long time. Then use of NSAIDs increase leukotriene synthesis. This we have already discussed, that the use of NSAIDs block cyclooxygenase pathway, and therefore majority of arachidonic acids are converted to leukotrienes, which causes increased in the synthesis of leukotrienes, and increased leukotrienes cause asthma exacerbations. So, caution should be used when giving non-steroidal anti-inflammatory drugs to asthmatic patients. Then, use of sulfa drugs like aspirin can cause allergy, hypersensitivity, and one of the features of hypersensitivity and allergy is the bronchoconstriction. Now, NSAIDs are contraindicated in pregnancy because they can cause delay in the onset of labor, they can increase the risk of postpartum hemorrhage, and they can also cause premature closure of ductus arteriosus. Now, ductus arteriosus is a blood vessel which should remain open in the fetus. Now, if NSAID is prescribed to a pregnant lady, uh, then these NSAIDs, they can cause premature closure of ductus arteriosus. That means they can cause closure of ductus arteriosus in a fetus, which is not desirable. So these are the adverse effects of NSAIDs. So this is in brief on the pharmacology of non-steroidal anti-inflammatory drugs. Please note that the information provided in this video is meant exclusively for students. And please kindly consult your physician before the use of NSAIDs. If you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.